All right. Good morning, everybody. It's 7:30, so we're going to get started promptly because I know other people have other places to be after this, and I just want to thank you all for choosing to spend your time with us this morning. Excited to have you. There's some statements I need to read at the beginning of the course, and this year I need my glasses as opposed to years past. This course utilizes audience response questions. To participate, you're going to text, and if everyone wants to take out their phone and sort of start the process now, you're going to text to the number 2233. So the number is 2233, but a slide will be coming up in a little bit, and then we'll show you what to type into that text number and then send it, and then you'll be into the audience participation. The AUA 2022 annual meeting mobile app is available and is free to download. Download the app. You'll be asked for your username and password. Use your email that you use to register, and then your password is AUA ID. I'm guessing most of you are already into the app already. So I'd like to just say again, thank you. Also state that the AUA policy states that all planners, authors, and presenters must disclose prior to their presentations their financial relationships, which we will do, with any commercial interest. These disclosures are posted on the AUA's annual meeting website. Please remember to silence your cell phones. I might do that myself right now. No photos, video, or audio recordings are permitted. Courses are selected based on their evaluation results, so we really appreciate you all filling out those. For every course evaluation that you complete, your name will be entered into a drawing for complimentary registration at next year's meeting in Chicago. You can evaluate this session by selecting Evaluate through the credit claim process, or going to the mobile app, click on the CME button, and then go to the CME page. We're going to have some pre-test questions today. You won't see the answers to those as far as how you respond, but we will obviously be giving you the answers throughout the day with the course. But then as part of our ongoing educational outcomes research, you will receive a post-test and course evaluation survey in 24 to 48 hours to determine the knowledge obtained. Completing an evaluation is required in order to claim credit for this course, and anyone who completes this post-test survey gets a random drawing for a $150 Visa gift card. So odds are pretty decent in this room, I think, if you do all this. So free trip to Chicago and perhaps a $150 gift card. So now we'll launch into things. So again, thank you for joining our course entitled Incorporating Genomic Testing for Prostate Cancer into Your Practice. I'm Joseph Wagner. I'm at Hartford Hospital. I'm the chief of urology there and the director of robotic surgery. As far as my disclosures, I actively consult for Medtronic, and in years past, I worked and did some work for Genomic Health, which is now Exact Science with Oncotype. I'd like to introduce our faculty, Matt Cooperberg from UCSF, Dan Lin from the University of Washington, and for any of you on Twitter, you're probably already aware that David Penson unfortunately has COVID, but happy to report that he's recovering nicely, so we'll try to stand in for him as best we can. So here are the instructions for the poll everywhere. So again, if you have your phones out and you text, like you're texting someone, 22333, and then in the typing part of it, type AUA meeting 818. And Leslie in the UNC Blue, my daughter goes to Duke, so I'm not so happy with that correlation I just made, but UNC Blue is happy to help you out if anybody's struggling with that. For those of you that can't text, perhaps from overseas, you can log on to the website address that you see there and accomplish the same thing. Everybody pretty good? A couple nods, good. All right, so here's just to get us started and get our feet wet. Test question 1 is, what do you love most about New Orleans? The AUA, of course, Creole and Cajun food, Bourbon Street, or the French Quarter? People seeing that on their phones? We've got 1 response, 2 response. Give it a few more seconds and we'll move on. All right, so AUA, of course. No Bourbon Streets. I guess the 7 o'clock in the morning people wouldn't have selected Bourbon Street, right? All right, learning objectives today. We're going to describe the seminal validation studies for prostate cancer involving genomic testing. We'll list the different prognostic endpoints provided by the various tests, identify appropriate genomic testing based on a patient's unique clinical characteristics, and review the NCCN Guidelines for genomic testing for prostate cancer. So now for our pre-test questions. The first is, somatic mutations can be passed from parents to offspring. And that's a true or false, and you're not going to see the results. But I can see how many people are replying. Oh, I guess you guys can too as we go. But obviously we will convey this information as we go, and then you'll be tested on it again in about 24 to 48 hours. All right, we're a little above what we were for the last question, so I'm going to move on. Pre-test question 2. Which genomic test reports prostate cancer mortality for prostate cancer patients managed conservatively? Is it Prolaris, Decipher, or Oncotype? For some reason, we got an answer on that one, but all right, we'll see how we all did. I think that's kind of more fun anyhow. And I think we're just going to have to guess on the time. Did I go one slide too many? No? All right. So we'll just wait about the same amount of time, and then we'll move on. All right, pre-test question 3. Which of the following is an indication for germline testing? And it's either a patient diagnosed less than 60 years of age, a patient with a prior history of lymphoma, patient with African ancestry, or a patient with Ashkenazi Jewish ancestry. It's tougher for me to do the statistics in my head when there's 100%, because I don't know if one person answered or 12. Before I was doing a little bit of dirty math in my head, but now it's a little tougher. All right, that helped a little. All right, next question. Question 4, which of the following tests is univariate? Prolaris, Decipher, or Oncotype? And the last question. A patient has adverse pathology on his prostatectomy specimen and would like further information on his risk of metastasis and need for radiation. Which test do you order? Is it Prolaris, Decipher, or Oncotype? I'll also take the opportunity now to let folks at home know that you can submit your questions virtually. I'll be manning my phone. I'm happy to answer questions as we go along. For those in the audience, we'll have a time at the end to ask questions. Obviously, you can feel free to come up to the table when we're all done and ask any other questions. All right. So course outline, I'll be providing a quick overview and background. Matt will be talking about pre-diagnostic markers along with germline testing. And then Dan and I will talk about genomic testing at diagnosis. Dave Penson would have been speaking about genomic testing post-radical prostatectomy. Like I said, I'll step in for him today. And then we'll have cases with audience participation with Dan, but along the way, we're also going to have an index case, and instead of using the audience participation poll, we're just going to do a raise of hands, which is obviously a little quicker and easier, so don't be shy. So background. First of all, the difference between a somatic and a germline mutation is germline mutations are inherited from your folks, and you can pass them off to your children. A somatic mutation occurs in an organ, in your prostate, in your colon, etc. Genomic tests examine somatic mutations in the tumor itself. Sometimes we refer to these as molecular tests or assays, and this is where it gets, I think, a little messy, because we're calling all these genomic tests, but they're really very different. Some of them aren't looking at mutations at all. ConfirmMDx, for instance, looks at hypermethylation. There are various protein tests, etc. It's just a nomenclature that we've thrown on them, but I think it's important to understand the differences. There are genomic tests, molecular tests available everywhere, every step along the pathway, from a man being concerned about prostate cancer to having advanced disease. And for the purposes of time in today's course, we're going to take you from screening up to post-op treatment, but we're not going to talk about advanced disease. So going back to Biochemistry 101, DNA gets transcribed into RNA, and then RNA gets translated into protein. And we have tests available at each step along the way to help us answer some questions. So for instance, at our place, we use IMPACT with this genome sequencing from Memorial Sloan Kettering. A lot of the tests that you're going to hear about today, like Oncotype, are RNA-based. And then there are protein-based tests out there like ProMark, P10, et cetera. So why do we need genomic testing? Well, we all know that we use these various tools, tables, nomograms, et cetera, to try to differentiate our patients from who needs treatment and who doesn't. And if they do need treatment, how aggressive do we need to be with that treatment? But we also know there's significant rates of upgrading and staging as well as downgrading and staging. And a recent study from European Urology showed that about 30% of men that are favorably intermediate are actually upgraded or upstaged at surgery. So back when the NCCN brought up the idea of keeping an eye on favorable intermediate risk disease, I went back and looked at 3,700 of our radical prostatectomy specimens just to see if that seemed like a very good idea. And when I looked at our favorable intermediate risk disease, again, about 27% are upgraded or upstaged, just like that European study we just showed. And this was the risk for low, or the rate for low risk. And then for unfavorable intermediate risk, it was 48.5%. So our sort of thought on this was, you can keep an eye on these guys. They seem to be more like low risk than unfavorable intermediate risk, but time will tell. When we look at the NCCN guidelines, the arena I think that genomic testing plays the highest role after diagnosis is for low risk and favorable intermediate risk disease. So it also plays a role in any of the other categories, except for perhaps, in my opinion, very low risk. And when you look at the risk stratification based on the biopsies, these are the three that we chose to talk about today. And the reason we chose to talk about these is I think they're the most common, number one. And number two, they're recognized by CMS. But as you can see, there are others that we're not going to be discussing today, such as P10. In the post-prostatectomy setting, then it's Decipher and Prolaris. So which test do you use? There are many pre-biopsy choices that Matt's going to be talking about, and the sequencing is very nuanced. I told you the reasons that we chose these three tests as far as after biopsy testing. And then I think you need to decide which endpoint makes the most sense to you. What's more useful to you? Do you want to know their prostate cancer specific mortality if they try to keep an eye on this? Do you think that adverse pathology is a better outcome? Is metastasis a better outcome? And then I want to stress that there is no best test. So I took 22 men who had two tests, really their choice, and I compared them. And they agree most of the time, and you hope they would if they're good tests. And what we found was that Prolaris was a little bit more apt to tell us that the man should be on active surveillance, and the other two a little bit more apt to tell us that they should have definitive treatment. But that doesn't mean that one is better than the other, right? I mean, we're trying to all figure this out, I think, with every patient we see in the clinic. And then I think you need to look at the literature. Obviously, you use evidence-based medicine to make your decisions, and then look at your prostate cancer volume. So are you comfortable with one test, or do you want to change with the clinical situation? So our index case, so now we're going to go with the show of hands. We have a 62-year-old man, PSA 8.2, repeated 7.8 with a free PSA of 20%, no past medical history. His brother had a radical prostatectomy at age 65, mild lower urinary tract symptoms, good erectile function. So what is your recommendation? So transrectal ultrasound and biopsy, you think he deserves a biopsy with or without an MRI? Would you get an MRI and let that guide your decision? Or did you get one of these adjuvant tests? So how many people would proceed with a biopsy with or without MRI? How many would get an MRI and then let that guide them? And how many would get an adjuvant test? Great. All right, I'm going to hand over the podium to Matt.
So the question's a perfect segue into the first part of the next part of the course here, which is really this question about pre-diagnostic markers. Excuse me, a growing number of tests that we have to help make decisions for men with elevated PSAs to help decide who does in fact need a biopsy and who does not. I have worked with a number of the companies whose products we're going to be talking about today. It's really important to frame any conversation about any of these tests, whether we're talking about MRI or the other liquid tests, from the framework of what we already know about screening. And the reality is, for all the controversies and for all the maligning of PSA over the last decades, it is probably the best biomarker we've ever had in the history of oncology for screening in the liquid state. We just haven't used it well, is the problem. PSA is a beautiful test to rule out prostate cancer for a young man. Around 45 to 50, we can basically write off prostate cancer for the next 20 years in terms of risk, and we can do that for about 75% of the population if we use PSA well with a threshold of 1. Not 4. But that's, of course, not how it rolled out. When PSA was introduced, because of the way it was initially studied, it was tested mostly in older men who had a lot of BPH, which is how we came up with this 4.0 threshold. And the result is that we wound up over-screening older men, we under-screened younger men, and of course, when we found prostate cancer, we over-treated the low-risk disease and under-treated much of the high-risk disease. Despite all that, we drove the mortality rate down 50% in the PSA era, and at least half of that decline is pretty clearly attributable to early detection and better treatment of screen-detected cancers. So if we used PSA better, more prevalent early baseline testing, we could continue to drive that bar down and avoid some of the continue to work on the overdiagnosis problem. So the point of all this is that the bar is actually relatively high to do better, because we already can do quite well. And just to stress this point about the thresholds when you test early, there's been a number of cohort studies now which are, these are not randomized trials, and therefore they are not included in the AUA guideline or the U.S. Preventive Services Task Force, but they are reflected in the NCCN and the ACS and many of the others, which have looked at, again, early baseline PSA testing and really looking to predict what happens over the long run. These cohorts are summarized in a paper by Mark Preston a couple years ago, which focused on the Southern Community Cohort Study, which is on the left here. This is a heavily African-American cohort. The Physicians' Health Study, of course, out of Harvard, is largely Caucasian. And then the Malmo Preventive Project on the right is the original one from Sweden, which followed men who donated blood in 1982 and were followed for 25 years and then had their PSAs checked retrospectively. And the amazing thing is, across these different cohorts, different racial backgrounds, different time periods, different countries, the results were incredibly consistent, that the median PSAs by age were really pretty consistent across different contexts. So the median in your 40s should be about 0.7, 0.8 by the time you get to your early 50s, around 1.0 by the time you get to 60. And over the long term, the men who are below the median and even men who are below the 75th percentile have basically no risk of dying of prostate cancer out to 25 years of follow-up. Now, for a 40-year-old, that's not to say you're done for life, but we can clearly back off on early detection. Notice 4.0 is nowhere near this slide, okay? And men who in this age range, if you have a PSA even 1.5, you're in the top quartile. By the time you get to 2, you're well into the 90th percentile. So it's a real reframing of the conversation with primary care. Now, we cannot talk about screening with a PSA threshold of 1 if we're going to take everybody with a PSA of 1.2 straight to biopsy. And that's where all the markers come into the discussion. So this is the growing list. It's getting harder and harder to update this slide every year because there's too much stuff to cram onto it. But for every decision point now along our continuum from maybe, should we even check a PSA, depending on how you choose to interpret the SNP test that I'll talk about in a little bit, on through whether to do a biopsy, whether to treat, and how to treat advanced disease, we've got almost more markers at this point that we know what to do with. And imaging, MRI and PSMA PET-CT very much play in the same space, and a lot of the same considerations apply. So focusing on this pre-diagnostic space, should we do a biopsy? If the biopsy is negative, should we do a second one? We've got a number of tests to discuss now. To be clear, this is a course on genomics. The blood tests are not technically genomic. They're proteomic, looking at PSA isoforms, but there's so much similarity in terms of study design and utility. I will include them in this review. Now, to emphasize the point again, and we'll make this point both for pre-diagnostic and post-diagnostic, for a test to have value, it has to improve on a multivariable gold standard. So if we're talking about post-diagnosis, we've got to do better than all the clinical information available on the chart at the time of diagnosis. Same thing is true pre-diagnosis. So we have to beat not just PSA, but some multivariable tool, whether the ERSPC or the Pcpt calculator. And it's really, really essential that these be done well. And there are sets of criteria which are increasingly enforced by journals when you submit articles on markers, really defining how the cohorts need to be set up, how the markers need to be set up and assessed. And again, of course, it hopefully goes without saying at this point that the goal of screening is not to find prostate cancer, it's to find potentially lethal aggressive prostate cancer, which is usually defined as Gleason grade group 2 or higher, understanding, of course, that many Gleason grade group 2s these days are not much less indolent than the grade group 1s. So the tests to consider before first biopsy: in the blood, we have 4K and Phi, which are both PSA isoform tests. Subset tests: in the urine, we have PCA3, what's now called My Prostate Score, SelectMDx, and EXO. And again, multiparametric MR is very much in this space. And the point I was making before about the improving on a multivariable model, this is the Pcpt risk calculator, which is based on the original Pcpt data. It incorporates pretty standard information: PSA, age, race, DRE findings, and family history. And the reason I always highlight this one, I really like the smileyogram. I think it's a very good bedside teaching tool. It's about the only website I ever actually go to during clinic where I have to break away from Epic, because it's very quick to use. And this really does resonate well with patients. And a point that Ian Thompson made when they first published this years ago at this point is that you can show two men the same 7% chance of a high-grade cancer. One may choose to get a biopsy, one may choose not to get a biopsy, and those can both be perfectly good decisions as long as they're well-educated decisions and the man has had the opportunity to make that choice for himself. So in terms of improving on these models, most of the markers we're going to talk about have been shown to improve on a multivariable model, either that Pcpt tool or the ERSPC. So 4K and Phi have both been out for a long time now. They're both looking at subsets of PSA. 4K looks at, they both include PSA and free PSA. 4K also incorporates intact PSA, which is another isoform, and HK2, which is sort of a cousin of PSA. PSA is HK3. HK2 is another predictive marker. Another kallikrein, both involved with semen maturation. 4K, one thing that separates the two is that 4K does incorporate the clinical information in its report. So it incorporates the age, DRE findings, et cetera, and gives a % likelihood of high-grade disease if we went forward with biopsy. The Phi, which is, again, PSA, free PSA, and -2 pro PSA, you really just get a number. So maybe slightly less easy to interpret or less easy to use as a teaching tool at the bedside, although it is less expensive. These are really two of the only tests that have actually been compared head-to-head in a single cohort. Now, this is a study out of Sweden by Tobias Nordström and his colleagues a number of years ago now, and they frankly perform quite similarly. So we typically look at these things in terms of the AUCs for predicting prostate cancer diagnosis or high-grade diagnosis. So again, all cancers on the left, high-grade cancers on the right. The AUCs for the base model, which in this case was Pcpt, was pretty poor, only a little bit over 50, but incorporation of either one of these subset tests drove the AUCs up to about 70. We can look at this graphically. You want to see these ROC curves up and to the left, and there's very little difference between the model incorporating the Phi and the model incorporating the 4K. So PCA3, moving into the actual genomic tests now. PCA3 is a full-length mRNA, which is identifiable in the urine. It does require a DRE to get the RNA out into the urine. This was the first genomic urine test which really hit the market. It never quite took off originally when this came out about 10 years ago, over 10 years ago now, partly because it was initially studied with a single threshold. It doesn't really work very well with a single threshold. There was a lot of gray areas. And it also was never quite calibrated for aggressive prostate cancer. The best study here from John Way and the EDRN looked at PCA3 with 2 thresholds. And just like PSA, negative predictive value below 1 is extremely good. Positive predictive value over 10 is pretty good to find a prostate cancer. Same thing here. PCA3 below 20 has a very good NPV. PCA3 over 60 has a very high PPV, positive predictive value. And in the middle, you have a gray zone, and that's just the reality of the biology. This has now been added to PCA3 is the TMPRSS2 ERG as another full-length mRNA in the urine. This was originally developed by Scott Tomlins at Michigan, originally called the MIPS score, the Michigan Prostate Score. They now dropped the I, and it's the My Prostate Score, which is now being marketed. This improves on PCA3 alone and is now calibrated for prediction of aggressive prostate cancer rather than all cancers. The graph in this paper was these decision curves rather than AUC curves. These you want to see up and to the right, and ideally you want to see as much daylight as possible between curves across the whole range of threshold probabilities. And you can think about those as patients' comfort level with making the wrong decision, with undergoing an unnecessary biopsy or missing a cancer. And again, you can see quite good separation between the curves with the incorporation of this marker compared to the Pcpt model alone in the darker orange. Again, does require a DRE. The final post-DRE urine test is SelectMDx. This looks at 2 different genes, again, full-length mRNA in the urine, HOXC6 and DLX1. This has also been around for almost 10 years now, not quite yet, maybe 7, 8 years. This was developed originally with 2 cohorts from the Netherlands, has now been validated in the VA and elsewhere. And this was the first one to really double down on negative predictive value. So the way, the actual performance characteristics across these tests is frankly quite similar. But there are differences in the way the tests are reported. And this was the first one that really focused on negative predictive value. So when the test is negative, the report is very clear. This is a 95 or 98, depending on just how low it is, % likelihood that if we did a biopsy, we're not going to find a Gleason grade group 2 or higher. So it's a very good rule out test for men with marginal PSAs considering biopsy. Finally, ExoDx. This is back to PCA3 and ERG fusion. What separates this one from the other urine tests we've talked about is it's looking at RNA in the exosomal component of the urine. So rather than just RNA that is shed by a mix of living and dying cells, this is RNA that's actually packaged and excreted actively by the cells in these little exosomes, little vesicles containing nucleic acids. Because of that, it does not require DRE. And when this test launched, we initially didn't use it very much. We were mostly using SelectMDx at UCSF, but about 2 months after the pandemic started, they came out with a home kit, which has really given them a massive advantage because in an era where we didn't even want patients coming into the lab, we can send them a home kit, they return it to the company, we get a score report completely remotely. So how do all these perform compared to MRI? So the negative predictive value for all these tests is quite good, typically mid to high 90s. Well, what about MR? The negative predictive value of an MRI in the PROMISE trial was 76% for finding Gleason grade group 2 or higher. This was Hashamet's ARCH trial published about 5 years ago now. To be fair, this used a template mapping biopsy as the gold standard, so it was a more intensive biopsy than the systematic biopsies done to validate most of the liquid markers. But the reality is that MRI can miss quite a few high-grade cancers. And there's a tremendous amount of variability across radiologists in terms of their reads on this. So this is data from the NCI. You can call this the best case scenario possible for MR. This is Peter Pinto's group. They've been doing this longer than just about anybody. If you take the 2 high volume, which is HH, the 2 high volume radiologists at NCI doing nothing but reading MR all day, their concordance for the index lesion by PIRADS was quite good, over 90%. You can see down in the lower part of the graph here. For all lesions, it was around 70. Now, if you take the medium volume radiologists at the NCI, who do a lot of prostate but also do other things, their concordance for the index lesion was only 79, for all lesions down to 53, which is getting much closer to random. Stanford University, just down the street from us in San Francisco, maybe not quite the volume of MR that we have, but still does a ton of it, had the courage to actually look at their own data at the radiologist level. And if you look at the positive predictive value for having a PIRADS 5, Stanford University, excellent shop, does a ton of MR. The likelihood of actually having a high-grade cancer ranged from 40% to 80%, depending on which radiologist happened to pull your scan off the work queue. And that's Stanford. This is not low-volume community practice where the radiologists are doing chest x-rays and mammograms and everything else through the course of a day. Another great study from NCI pretty recently showed quite clearly that if we really want to find the aggressive cancers, it is much too soon to abandon systematic biopsy. We need to be doing the targeted plus the systematic if we want to find the grade group 2s and 3s, which I'm not ready to abandon identifying. And the final comment I would make about this is we really should not be abandoning ultrasound as a great diagnostic modality. When ultrasound is done well, this is not even micro ultrasound, this is standard ultrasound. We can see most of the lesions that we see on MR, certainly almost all the Pirates 5s, ultimately are identifiable on ultrasound. So, the liquid markers, by and large, have a better NPV for Gleason grade group 2 or higher than MR, and in this country, they're much cheaper. When we look at other contexts, almost every other health system in the world, MR costs a few $100s equivalent. Here, of course, it's thousands, and the markers are not available in most parts of the world. So, MR is really the reflex test in the UK and many other places, despite all these problems with inter-observer variability. Here, the markers are much more cost-effective than an MR and much more consistent. And as I said, there's now an at-home test at least for exo. It's also really important to point out that none of these tests, either before or after diagnosis, is truly binary. We want to test that if it turns blue, you take out the prostate. If it doesn't, you leave it in and tell the patient, don't worry about it. That is just not the way the biology works. These are all continuums. Okay? It's a continuum of risk before diagnosis when we're trying to decide whether to do a biopsy, likewise after diagnosis. So the question is now going to become, how do we integrate all this? How do we sequence it? We can do PSA followed by MR followed by biopsy. This was the question we just gave you guys to launch this. We can do this with a marker instead. We can do PSA followed by a marker, and then if the marker's positive, proceed with MR and biopsy. We can flip that, or we can do both marker and MRI on everybody, which is probably the most accurate, but also the most expensive. I will tell you at UCSF, we are typically in this sort of a sequence here, so men with an elevated PSA will get one of these markers. These days we're doing a lot of exo and 4K because they don't require the DRE. If the marker's positive, we will do an MR to help us do a better biopsy, but if the MR is negative, we're still going to do the biopsy. Now I do have colleagues, other academic centers whose paradigm is more like the next one over. They'll get an MR right off the bat and only get a marker if the MR is equivocal or negative. And that's another reasonable way to do it. We have no data and no consensus in terms of the best way to integrate these different tests. So to summarize, optimal PSA screening and use of these markers. Optimal PSA screening really should include early baseline testing, age 45, 50 ideally, but certainly not 69, which is the most common time to get a PSA test in this country. And if you're below 1, which a heavy majority of men are, you're really done. Do not check every year. They can come back in 20 years. Realistically, at UCSF, we're saying 5 years, but it could be much longer than that. Low threshold for further workup, but workup has many, many tests available now short of biopsy, in advance of biopsy. MR can help guide biopsies, so can ultrasound. I don't think these are good reflex tests yet compared to the liquid tests we've been talking about to help decide who needs to go forward with testing. There's a growing number of both blood and urine tests that are available. They all, like I said, perform pretty well, so it's a question of which ones make the most sense in your clinic workflows and patients can actually access. So, going back to the index case here, so actually any questions on that piece of it before we move on to Germline? Yes. Yeah, great question. So none of them have to be iced. So the exo test is a home kit. All the other urine tests are clinic collections. You do a DRE and then you catch the first part of the urine after the DRE. There's special media that the urine needs to go into, but then it goes back at room temperature and they just get UPS or FedEx back to the lab. The 4K test is, at least in our institution, is now a send out from the UCSF lab, so you can go to the lab and they send it out to OPCO, who actually does the testing. And I believe 5 can be done along the same paradigm. So they're easy. They're all pretty easy to do, but the home kit is the easiest. Yeah. Say again? Yeah, with the clinic staff mail or shipping. Yeah, great question. So if a man is on a 5-ARI inhibitor, then, yeah, do we interpret these tests differently? And the answer is generally no. So it is a really important point. And I would stress really this whole conversation about screening and primary screening and secondary testing really involves primary care, right? Because ultimately they're the ones doing the testing or not. And it's really important that the primary care docs understand this issue about finasteride and dutasteride dropping the PSA. There was actually a study from the VA a few years ago showing higher prostate cancer mortality for men on these agents. It is not because of the black box warning and some suspicion that the 5-ARIs are driving higher grade cancer. That doesn't happen. It's because the primary care docs did not mentally adjust the PSA, so there was a significant delay in diagnosis for men on the agents. The tests, by and large, have not been well studied among men on 5-ARIs. A couple of the validation studies actually excluded men on the inhibitors, or they just included them and took all comers. Mechanistically, there's not really too much reason to suspect that any of the urine tests would perform differently. I think with the blood tests, it might be a different story, but they're not data that I'm aware of. So we still interpret them the same way. But again, the critical thing with the 5-ARIs is the initial PSA interpretation.
But 4K has a question. Like 4K will get kicked back to you.
That's right. That's right.
The
4K will not
finasteride.
allow it. That's right.
Yeah.
That's right. Yeah, please. That's okay. So, yeah, so again, we did cover some of this. The MR negative predictive value is not that great. So patient who has a high PSA, and you have to think about age and DRE, and prostate size, PSA density. There's other things to consider in both of those scenarios. Above 1, yeah. So, there's a big difference between a PSA of 2.5 even, or 4, between a 47-year-old and a 69-year-old. A 69-year-old with a PSA of 2.5 probably doesn't have to worry about it. A 50-year-old with a PSA of 2.5 is in the 95th percentile and absolutely needs workup. Again, workup, we've got lots of tests to consider before biopsy. But both of those scenarios, there's a lot of factors to consider. I was at a UK meeting yesterday where they're doing a ton of MR as secondary testing, and one of the attendees made the comment that buried in the precision trial, which actually was a detail and supplement that I had not seen before, 30% of the cases called PIRADS 1 and 2 by the original radiologist got reread as 4s and 5s. So there is an incredible problem with consistency of PIRADS reads. So somebody who's got an indication for biopsy and a negative MR, we do the biopsy, systematic. Yeah.
How do you currently combine your biomarkers with the MRI to safely avoid anti-biopsy?
Yeah, so it's a great question. And this is in evolution. And the reality is we all probably even do this a little bit differently, even within my institution. And it's going to be a little bit customized, even patient by patient. Personally, I tend to start with either EXO or 4K because it's the ones I've used the most. We've done a lot of select MDX as well, but these days I'm seeing everybody on Zoom, so I can't do the DRE. So we do a lot of EXO. If the EXO test is negative, we're usually done. And I tell them, come back in a year, go back to primary care, depending on the situation. If the PSA is, if it's a really concerning situation, strong family history, PSA is really out of whack for prostate size, et cetera, we'll get both. I'll do the EXO test and the MR right off the bat. And again, if we have an MR, some folks are coming in with an MR, we'll look at it. If it's reasonable quality, we'll take it. That's more and more we can actually at least interpret the community MR. And if it's borderline, then we'll get a marker at that point to decide whether to go forward. So it is quite personalized, honestly. Depends on family history, prostate size, age, race. Lots of factors, go into what actually happens at the bedside. For sure. If both the tests are negative, we're good. And if the PSA is really high, out of proportion to everything else, I will talk about 5 ARIs for secondary prevention in that case, PCPT style. If for no other reason than PSA being patient-specific anxiety, patients feel better with a lower PSA, and it will often help with voiding symptoms too.
So will you do it in the lack of voiding symptoms?
I have occasionally. If men are worried, they've had a negative biopsy. I've seen the PSAs as high as 19.
But had a negative biopsy.
Negative biopsy.
Okay.
I don't think I've done it. That's a good question. I don't think I've done 5 ARIs without a biopsy. Yeah, that's a good question. Please.
My question is related to MRI. I can't recall the article. It's pretty convincing that the idea of the MRI is not as much prior to your first biopsy rather than for repeat biopsy. So, is there any solution you do, especially if so many DREs are normal, would you still do MRI? It's a very expensive study.
It's a very expensive study.
You don't get anywhere.
It's a very expensive study. Look, the slide that I went through kind of quickly there, we put 200 patients through consecutively in our practice where we blinded the urologists to the MR results, did an ultrasound lesion-guided biopsy, then took the drapes off the MR, did our fusion biopsy. We uniquely identified the cancer based on the MRI in 6.5% of the cases. So we can see most of this stuff on ultrasound. We've started doing micro-ultrasound now at UCSF as well with ExactView. And this is probably going to be as good as MR. I mean, when MR costs $400, which it does in most of Europe and Australia and pretty much everywhere else in the civilized world, it is a great secondary test. When it costs $3,000, which is what we somehow have decided is acceptable in this country, it's a totally different value proposition. So we do a lot of them. We get them almost as a matter of course. But you're absolutely right. If there's a clear nodule on a DRE, you're going to see that on the ultrasound. And there's really no reason to go for the MR.
One other question, are any of these pre-diagnostic tests showing value for minimal residual disease or recurrence after either whole gland or focal therapy?
Yeah, great question. The answer is no. The short answer is no. It's a great probably area for future investigation. They have been studied a little bit in active surveillance. Dan actually ran a great study in Canary, looking at actually a couple papers now, looking at these markers. There was another one from Hopkins at one of the poster sessions here yesterday. The bottom line is they don't do very much. Once you have the Gleason score, they don't add very much. The MRD question is interesting. I've not seen that come up. The thing about that is at that point, you've got the tissue. So we have the actual tissue genomics, which we're going to get into in a little bit, which are probably going to do better. But remeasuring these things after ablation is an interesting concept.
Do you think that this really needs to be in the remit of urologists and hands of urologists, or have you seen any trends or debate that this is now being handled by non-urologists, family doctors?
Yeah. Eventually, yes, but that's going to be a conversation. We've had a 2-year conversation with our primary care docs at UCSF, even to get PSA into our health maintenance banner. So something along these lines, actually, PSA threshold of 1, for early consideration for early referral. This is now baked into the UCSF EMR, and that was a long conversation. But one that we did ultimately prevail with. I think ExoDX or tests like this, can absolutely be used as secondary reflex tests in primary care. But the primary care docs really need to want to be involved with this, right? They need to put the time in to understand the data, and it's got to be very tightly, clearly protocolized for them. They do not want to get into the nuances of family history and race and DRE and all this stuff. 1 number threshold, do I get the test or not? If the test comes back, at what point do I need to refer to urology? So we've been talking about it with at least a couple of the primary care clinics at my, in our health network, and I think we'll get there eventually, but for now it's all urology. Great. All right, good. Good questions. Thank you all for participating. All right, you're stuck with me for one more section of this. So moving on with our index case now. So our 62-year-old gentleman here with the PSA 8.2, repeated, and sorry, that's a point that we should emphasize here. Elevated PSAs should absolutely be repeated. This is clear in the AUA guideline. It is not remotely uncommon to see a low PSA that spikes up and then comes back down again, so should always be repeated. This one was repeated, still quite high. Marginal free PSA. He has a family history. Brother was diagnosed at age 65 and underwent surgery. Does not really remember any of the details about that. So he had a 4K done, showed 23% chance of clinically significant disease. Pyrites 3 lesion left mid. So he went forward with a biopsy. We found 8 cores out of 12 with Gleason grade group 1. Reasonable involvement of each of the cores. So, is he a candidate for germline testing? Show of hands. Who would do germline? Just one. Who would not? Everyone else? Okay. All right. So let's talk about the germline. So this is a different conversation because here we're really talking about patients who may be even upstream from PSA testing. We've already been over the key definition here. These terms are of course arbitrary. It's just how we use them by convention. When we talk about genetics, we're typically talking about the germline, the DNA that you're born with. When we talk about genomics, we're referring to alterations either in the DNA or in the regulation of the DNA, its expression, its transcription and translation in the cancer cells themselves. So the evidence here is really evolving really quite quickly. There's this Philadelphia consensus, which has now happened twice already within a 3-year span. 2020 was the second one, to really try to come up with consensus recommendations in terms of who should get tested. And the list of relevant genes which are associated with prostate cancer risk is growing every year. Now, where there's still a real lack of consensus from this consensus conference and pretty much everywhere else is what to do with the results and how to actually screen differently among men that do have mutations, and we'll come to that. The NCCN also has its own separate guideline now specifically on germline risk assessment. So the criteria for indications for germline testing according to NCCN include family history of a known mutation, Ashkenazi Jewish ancestry, strong family history of prostate cancer. So this is not just my uncle got it at 87 and was on active surveillance. If you've got more than one first-degree relative diagnosed before 60, more than 2 or more prostate or breast cancers in first-degree relatives, or any metastatic or high-risk cancer. And if you have 3 cancers on the same side of the family among the whole cluster of heritable cancers in this family of germline mutations, including colon, urothelial, breast, pancreas, and ovarian. So most of the genes that are on that list are in the family of genes associated with DNA repair mechanisms. So BRCA1 and 2, ATM check, most of these are in this homologous recombination pathway, which is part of the cell's proofreading apparatus, intended to deal with recombination defects when the cells are undergoing mitosis and the chromosomes are re-annealing. There's a number of genes, a number of proteins that are part of that process, and defects in any of them can predispose to cancer. So the rates of germline mutation really depend on which population we're looking at. There was this Pritchard study in the New England Journal 7 years ago now, which really kind of got this conversation going, which reported almost a 12% chance of an identifiable mutation in the DNA repair path among men with metastatic disease. And that's an important caveat there. This is a highly selected population. Now from TCGA, we can look at the same question. For men with high-risk prostate cancer, it's about 6%. And you can see the distribution here. BRCA2 is by far the most important single gene. BRCA1, of course, mostly associated with breast cancer, is a player, but not nearly as much as 2. ATM and CHEK are the sort of second and third most important. Now, when we get out of high risk, these rates drop. So, there have been a number of different additional studies since the Pritchard paper. So again, the Pritchard paper has held up. So the rates of mutations among patients with metastatic disease, around 7 to 16%. High risk localized, 6 to 9%. Low risk localized, though, we're down to about 1.5 to 3.5%. And this is actually about consistent with the general population, where we see about 3% rate of mutation in this population. Now, this is skipping forward a bit, but there has been this whole question about, do we treat differently when we find these mutations? This is a paper from Hopkins, which is the only one so far that has really drilled down and looked at outcomes of active surveillance split by BRCA status. And this is the Castro study. This is looking at among patients with advanced disease progressing to metastasis, much higher likelihood of progressing to metastatic disease for patients who have a BRCA mutation compared to those who don't. We're going to talk about the active surveillance one in a little bit. However, in prostate cancer, unlike breast cancer, where BRCA1 and 2 explain a lot of the identifiable breast cancers, all these single genes that we're talking about are relatively minor players. And this concept of the tip of the iceberg is that we know from linkage studies prostate cancer is the most heritable cancer, but all these mutations together account for a pretty small fraction of identified inherited prostate cancer patterns. The rest, we kind of say is unknown, and maybe genes that we haven't identified yet, but it's also very likely polygenic. It's the way the genes interact with each other that establishes risk rather than single genes. So there's a number of these polygenic scores now based on SNP panels. These are very cheap to do. You can do them from blood or saliva. And these, the question is where these are going to be used. The teams that are developing these are enthusiastic that this will help us decide who needs a PSA test. I personally think it's extremely unlikely in the foreseeable future that a primary care doctor who can barely wrap their head around, what the right threshold for a PSA should be is going to figure out how to do germline testing and interpret, how are we going to think about a PSA differently if the guy's got a SNP score of 37 versus. I just don't see it happening. Now, when we get into the next generation of completely non-justified, unnecessary whole genome sequencing that a subset of people are going to do at the shopping mall with 23andMe or what have you, we're going to get guys who have their whole genome and will be able to calculate one of these scores based on the whole genome. So, just as one example here, there's a number of these studies coming out now. The positive predictive value of an elevated PSA ranges from 7% to almost 25%, depending on your genes. But all the money here is really in the extremes. So this is looking at below the 20th percentile versus above the 95th. And most patients are going to be in this sort of average risk. The combination of the polygenic risk scores with the individual mutations also gives us more information. So this is looking at the odds ratios for identification of high-grade disease. And the dark blue line, the x-axis here is the deciles of risk according to the polygenic risk score. And then the dark blue versus light blue is if you do not or do also have a single gene mutation. So you can see that the combination of these really gives us the most information. And yeah, look, if you had all this information, you could comfortably tell the folks at the far left, you really don't need to worry about this, don't even get a PSA. And the guys on the far right, need an annual PSA, and eventually we're going to find cancer. It's a question of when, not if, and we need to be sure not to lose these guys. But again, from a primary care standpoint, because this is a primary care conversation, not a urology conversation, are we really going to do this upstream of an early baseline PSA? Maybe someday, but I don't think it's going to happen in this decade. So this is the active surveillance study I was talking about before. This is from Hopkins, looking at likelihood of reclassification to higher grade disease for men with mutations. So the top graph here is over time for men who have got BRCA1 or 2 or ATM. This bottom graph restricts it to men with BRCA2 alone. And you can see there is a much higher likelihood of reclassification among men with mutations. The question becomes, do we tell these men they're ineligible for active surveillance? I personally do not feel that way. You look at this graph here, by 6 years, 50% of the men with mutations have reclassified. Well, great, 50% haven't. They're still low grade at 6 years. And the reality is reclassification is usually to a low volume Gleason grade group 2, and the cancer is still eminently curable. The number of these men where we think we're really missing the window and they were curable at diagnosis and now it's too late, those exist. Those are certainly not quantified in this study, and I think they remain very, very rare. These men need close surveillance, and we tell them these are men who absolutely need the PSA every 6 months. They cannot skip biopsies. They need intense surveillance if they're going to go down the surveillance path, but it does not mean we need to go straight to prostatectomy or radiation for every 52-year-old with Gleason grade group 1 in one core just because they've got a mutation. And finally, some of these mutations, this is much more relevant to medical oncology, but we're getting to the point where some of these mutations are actionable at the standpoint of managing advanced disease. Of course, there's a lot of interest in PARP inhibitors, which are particularly relevant for men with mutations in these pathways. The same is true for platinum-based chemotherapy. As we identify these earlier, it may be the case that we can find subsets of men who should get PARP inhibitors early in the pathway. And I'm not going to go through all the details on these, but there's a number of trials now showing benefit. One is the particular benefit for men with mutations. One of the challenges, though, being that there is not a great readout yet in terms of how we can identify the men with the mutations who are going to benefit the best from PARP inhibitors. So a lot of the trials have been done across men who do and do not have mutations. Those who do better. They have more of a response to the medication, but it's certainly not a black and white question, and I think there's still a lot of open questions in terms of identifying the men best suited for PARPs. And there's a number of trials in this space. I'm happy to go through it if you guys would like, but this is much more of a medical oncology question for now. There is also thought that men with microsatellite instability, which is also read out on a lot of these genetic tests, might do particularly well with immunotherapy using PD-1 or PD-L1 inhibition. And there's a number of other targets. The AKT pathway, which is PTEN, can now be targeted with these PI3 kinase inhibitors. There's a whole set of, we're going to enter this era very soon of truly tailoring systemic treatments based on both germline and somatic genetics. And it's a very exciting era. The question finally becomes then, are we testing enough men? And this goes back to that initial case. This is a conversation that we definitely do need to be launching as the urologists for men who do have high-grade disease, anybody with metastatic disease, men who've got a high-grade cancer, especially at a young age, or those with strong family history, really should be thinking about genetic testing, both because it can affect what medications they're eligible for later, and it's important information for the family. But we do know data, at least as of a couple years ago, most eligible men are not yet being counseled or referred for testing. Now, there's lots of different models in terms of who does this. Should the urologist actually order the test? Do they send them to a counselor? Basically, the model is either the urologist does the counseling, orders the test, and sends them to the counselor only if the test is positive, or you can send them to the genetic counselor to have the whole conversation about genetic testing and let them run the whole conversation. I have absolutely no feeling on this as long as it works for your practice and you've got a good genetic counselor to work with. And I also have really no feelings in terms of which particular test to order. This is 10 different lab tests and which genes are included in them. They all include ATM, BRCA1 and 2 and check. We happen to use Invitae at UCSF. There's Color. There's a number of them. These are pretty easy to do. They're pretty inexpensive, and their access to them is increasingly good, and they're increasingly covered by insurance as well. So that's really it. Obviously take a good family history to start, to identify the men who really should be counseled for genetic testing. And it is important to really think about an algorithm here so that it will be easy when you identify patients who are eligible. And that's where I'll stop. Any other questions?
Can I make a couple comments real quick?
Yeah, please.
Yeah, so before we do that in this case, on this germline testing, I think I get a lot of comments from my patients saying, oh, I'm going to go get an Ancestry or a 23andMe. That's not what we're talking about. I mean, this is like really, it's much different. And I think patients and even providers get confused about that. And the other comment on the, editorially on the active surveillance setting, that was 26 patients out of over 1,000. So those men in active surveillance that were worried that in that study were 26 patients out of over 1,000. So it's a pretty, are we gonna test 100 men to find those two or three people that have these mutations? I'm not sure it's going to have a big effect on who you're going to do active surveillance on. So really, practically speaking, as urologists, is that really going to affect us? Probably not. But as we discover new variants, I think it will. But right now, I question it too. Yeah.
Totally agree.
Questions?
Please.
Yeah, a couple questions about the polygenic risk score. The first one is, the models right now are based on the incidence of prostate cancer, not really, metastasis-free survival.
Yes.
Specific mortality. Is that data, is it just because the biobank data dump doesn't have enough data there in terms of patients who died of prostate cancer to develop metastatic disease for the polygenic risk score to be based on that outcome? We're just waiting till we have that data to improve it?
Great question. So first of all, yes, the GWAS studies that identified these SNPs were based on prostate cancer, yes or no. These are large, multi-tens of thousand patient sets, typically international. They are just now, so that's always been the endpoint. These have been driven by genetics folks, not really by urologists or oncologists. There are a couple papers that are now starting to look at these after diagnosis to try to do prognostic stratification. Bill Catalona had a paper out in JU a few months ago. It's the first one that, there are some issues with the way the paper's set up, but it's one of the first ones to show that they may actually drive outcomes of active surveillance. It depends how you define the outcomes, and I am personally slightly skeptical that these are going to outperform the other tests we're about to hear about in terms of telling us very much after diagnosis. I think they might be additive, maybe, but once you've got the tumor, on a slide, and you can actually interrogate the RNA, which again we're going to talk about in a second, you're going to learn much more about that cancer's potential behavior. So the SNPs, they are intended to predict prostate cancer. They're being studied to predict high-grade cancer, but they're not really set up for predicting METs. There was another nice poster at the session yesterday from the Harvard Professional Follow-up Study Group. looking at the SNPs, and they do not pan out when looking at the lethal prostate cancer endpoint that they've really been driving in HPFS. So it may well be that there are different SNPs, that there's different genes, but you've got to find tens of thousands of men with those endpoints to do that sort of GWAS.
So, yeah, and just the other point on that, I think what's going to happen, and we've looked, a lot of people have looked at whether it's a yes/no prostate cancer. That's the problem. But if it's yes prostate cancer, it's bad prostate cancer. That's the question, right? And nothing's panned out. Although the most recent data shows that if you combine the PRS, which is multiple SNPs, multiple germline defects, with the rare bad variants, the BRCA1, 2, ATM, the combination of those two, and they're rare, actually might predict some higher lethal cancer. But right now, unfortunately, it's a yes/no binary. You have cancer or not.
And the second question, or maybe it's just a comment, is I think the real interesting part about the apologetic risk score is that it's not siloed. You know, the PSA only tells us about prostate cancer, but with a single saliva swab, you get the risk of major adverse cardiovascular events, which are 4 to 5 times more likely to kill the patient than prostate
Yes.
cancer, for dementia, for
Sure,
lung cancer.
sure.
I mean, you get all of that with just one screening test. So that's kind of the interesting part.
Yes, we're going to get there. I don't know that you were really getting 4 times. I mean, you know what I mean? There's a lot of claims about this stuff. Of course, I'm not tracking the dementia literature all that tightly, but how well these things really do, I'm not so sure yet. And there's a lot of marketing, and it's going to be yet another sort of disparity problem too. We already have an issue where high SES men get worse care in prostate cancer because they have much higher rates of overdiagnosis and overtreatment. Historically, and it's going to be another round of this when the guys go to the shopping mall and get I've now seen men who got a whole body MRI at the mall for $1,000, and somebody called a Pyrides 3 on this non-cut. I'm 36 years old, and what am I supposed to do with this guy? PSA of 0.4. It's nuts. So look, we're going to get there. The Gattaca, your child will be a basketball player, and should. We'll see. We'll see.
The pan-cancer
Yeah.
screening, single blood draw. I mean, AUA, 2032 or something. It's going to happen, but not yet.
Yeah, not yet. Not yet. All right.
So back to our index case, we learned from Matt that this gentleman is not a candidate for germline testing despite his 65-year-old brother. And what next? So show of hands for active surveillance for this gentleman. High volume, grade group 1 disease. How many would get genomic testing? And how many think he deserves definitive treatment? Great. All right, so we're going to launch into the genomic testing on the biopsies. So I'm going to talk about Decipher. So man's diagnosed, again, this gentleman with low-grade, high-volume disease. Are we going to move toward active surveillance or definitive treatment? And right now, we base that on various nomograms, tables, et cetera, that incorporate Gleason score, age, PSA, number of cores, et cetera, but we know that that's not accurate. This gentleman here is favorably intermediate. Some of those guys do great and should be on active surveillance, and some not so great and probably deserve treatment. So is there any way we can sort of separate the wheat from the chaff? So Decipher is one of the tests available to help do that. And what we're trying to do is divide these gentlemen who look the same based on our standard criteria into a different box. And Decipher does that on a continuum from 0 to 1.0 and divides them into groups called low risk, intermediate, and high risk. So again, without genomic testing, these gentlemen look similar by PSA, grade group, et cetera, and with genomic testing, we've placed them in a different category. So the endpoint for Decipher is metastasis. And I think with all these tests, we can either look at biochemical recurrence, metastasis, or death, and those things are a continuum. So obviously not everybody who has a biochemical recurrence goes on to metastasis. Not everybody who gets metastasis goes on to a death. So Decipher is a 22 gene test across 7 pathways, RNA-based. And when you look at it, it was designed to be an accurate predictor of metastasis, so you would expect it to be. And the area under the curve is about 0.81. When you compare that to the other things that are out there, it performs better. When you get your Decipher report back on a biopsy, this is what you see. And what you see is what is the risk of metastasis that this gentleman has if he undergoes definitive treatment, defined as standard radiation therapy or surgery. What are his risks of prostate cancer mortality over 15 years? And what are the risks of adverse pathology at surgery? And the way that it's defined by Decipher is T3B or grade group 3 through 5 or lymph node involvement. T3A in their studies, Decipher was not predictive, as opposed to some of the other tests like Oncotype that we're going to hear about in a bit. In addition, Decipher will give you something called a grid that is designed to give you a bit of a better idea of how sensitive this particular tumor is to radiation, androgen deprivation therapy or not. Again, I think we're early on in really applying those things, but that's what the company's striving to do. You get an idea of where you fall in the continuum. I always call this the American Jones report because everybody wants to know how they compare to somebody else. You know, personally, I'd rather have my kid, graduate last from Harvard than first from what's the matter you. So I'd rather have the worst aggressive low-risk cancer that's out there than I would a better high-grade cancer. So you have a candidate for active surveillance. You run the test, and the idea is it defines who is a better candidate for definitive therapy and who should continue with active surveillance. Generally, the cutoff for that is 0.45. Again, the test is a continuum from 0 to 1.0. And here's the negative predictive value. And the negative predictive value, if your score is less than 0.45, is very good. So I think that's what most people are using for a cutoff to determine who their active surveillance population is. This is a study from Matt in European Urology in 2018. And again, it's a continuum. As the increased genomic score goes up, you have a higher risk of developing metastasis. Those are men that you might want to step in on a little bit earlier and give definitive therapy. I think the new arena is obviously favorable intermediate risk disease. Quick show of hands. Matt put his hand up very high for our high volume grade group 1 disease, right? So if that's the worst of the low risk, and we're very comfortable following those folks. The favorable intermediate, we've only been doing it really according to guidelines for about 4 or 5 years now. And when you divide favorable and intermediate risk disease by Decipher score, and then you look at adverse pathology features at surgery, what you find is if they have a lower intermediate Decipher score, those gentlemen have a risk of adverse pathology very similar to very low and low risk men. Whereas if they have a high score, it's more like unfavorable intermediate risk. So what we're trying to do is, like the table I showed at the beginning, figure out which of these patients are more in the low risk group and who is in the unfavorable intermediate risk group. So here's a gentleman, low risk disease, has a Decipher score of 0.30. That would drive us, I think, toward active surveillance. But here's a gentleman who's also low risk, and he's probably low risk because of his PSA density, just looking at his PSA because he only has 2 cores. But he has a risk score of 0.80. That's a gentleman that you might want to consider for definitive therapy. So once you've decided whether a man's going to undergo active surveillance or definitive therapy, these tests can also be used to decide how aggressive should your treatment be. So if he has higher risk disease, again, you're a little bit more worried about him. I personally haven't really used these yet into my algorithm when I'm in the operating room to decide if I'm going a little wider or not. I'm probably doing it in the back of my head, I suppose, but I certainly don't have anything formal. In the radiation world, there's more evidence-based medicine to sort of base things on. So this is a study that showed in 121 patients that if you had a low Decipher score, your chances of developing metastasis down the road was very low if you were treated with radiation alone. But if you had an intermediate or high score, your risk of developing metastasis was higher. So this really supports, current guidelines, I think, for unfavorable intermediate risk and higher of giving concurrent androgen deprivation therapy. So another study that says that this test helps us identify patients who may need intensification. And again, what you see is that these men, and this was from Dana-Farber, received radiation therapy in a short course, 6 months of ADT. 60% of these patients were low risk. They hardly ever develop metastasis, but the high-risk men do. Begging the question, would extra androgen deprivation therapy help? Should we give higher doses of radiation? Can we adjust our treatment paradigm? So again, typical patient, 71, 5.8 PSA, favorable intermediate risk disease with grade group 2. He comes back with a Decipher score of 0.30. He probably should get radiation alone. And that's what he would have received anyhow based on the NCCN guidelines. But similar gentleman, again, favorable intermediate risk disease with a high risk Decipher score. Maybe he deserves 6 months of androgen deprivation therapy based on those prior studies. Take it a step further. Right now, really, in NCCN guidelines, genomics is not indicated for unfavorable intermediate risk disease. But if you had a gentleman with, and I see these guys all the time, they really want radiation, but they don't want the androgen deprivation therapy. So I might do a Decipher test on that gentleman, and if he comes back at 0.30, I'll have a discussion with the radiation oncologist, and we'll talk about the pluses and minuses of foregoing that 6 months of ADT. But if he has a Decipher score of 0.80, unfavorable intermediate risk, then I think he certainly deserves at least the 6 months. So when you look again across the paradigm, the first question is active surveillance or definitive therapy. And if they're low risk, they go toward active surveillance. Intermediate or high, again, using a cutoff of 0.45, I tend to recommend definitive therapy. If they're going to get definitive therapy, do they get radiation alone? Radiation and hormones, and maybe in the back of my head I'm taking this into account in the operating room subconsciously, but I certainly don't try to. And then the duration of hormone therapy. If they're going to get radiation, do they get just a short course, 6 months, or do they deserve the 1 to 3 years that our higher risk gentlemen receive? So I'm happy to entertain any questions about Decipher, otherwise I will turn the podium over to Dan. And obviously, there'll be opportunities at the end of this just to ask genomic questions in general.
Yeah, perfect. Okay, so I'm going to take you through the other 2 major platforms, that being Prolineus and Oncotype. I always, when I'm talking about biomarkers, I have to make sure that we look ourselves in the mirror and say, well, are we doing the right thing compared to other groups? Now, I have some disclosures. Of course, like all of us, we interact with the biomarker companies, receive funding. I put this up all the time, and this is breast cancer. And why are we at the AUA looking at a breast cancer guideline? Because this is the challenge, in my opinion. The challenge is breast cancer because they have readily available markers that they've used for decades. They have this issue of whether they're ERP or positive or HER2 positive or negative. And this is like the most common breast cancer subtype. It's a ductal ER positive, HER2 negative patient. And, this is my mom. My mother had breast cancer. So you look at this, and on this guideline, right there in the middle, there's a test. There's a biomarker. And it's actually on the guidelines, which tells or lets us know perhaps to give adjuvant endocrine therapy, perhaps to give chemotherapy. It saves a lot of women chemotherapy in the adjuvant setting, and it's on the guidelines like in the flow chart, not in a footnote. And then you look at how they've come about this, and they've done clinical trials. And this is the Taylor RX trials. It was years ago, but they actually looked at thousands of women on a clinical trial, and they did use this test. And it, again, saves women from getting chemotherapy. Here's our guidelines. There's no, unfortunately, AR positive, androgen receptors positive, and, most men having prostate cancer. So we don't have a hormone receptor positive or negative. We don't have a HER2, and we don't have any biomarkers in here. I'd love to get to a time, again, we're joking about AUA 2032, but I think it might get there sooner. All the biomarkers are on the guidelines. So all the biomarkers we're talking about now are on the guidelines. They're just not up in this highlighted place yet. And I'm hoping that it will be. We're very much, all of us are very much pro trying to get biomarkers on the guidelines. Same thing with favorable intermediate risk. If you look there, it can be doing nothing versus doing something very radical. Again, how can we get biomarkers to help us? Even in the lower part there, where if a man has a prostatectomy and you that do these surgeries, you take a man's prostate out and he has adverse features, and even lymph node positive disease. And the choice is do nothing versus do something with toxicity. So why isn't there a biomarker there? We're trying to figure much of this out. So having said that, that's a little soapbox, but I think it's important to know that we are pushing ahead and we can use biomarkers differently. So what about the two platforms I'm going to talk about? One is Prolaris and one is Oncotype. So Prolaris is based on, you go back to medical school, Ki-67, which was how fast a cell divides, cell cycle. It's based on cell cycle, how fast cells are dividing. It's a 31 gene panel. There have been multiple published endpoints, so I'm going to work through a couple of these things. But they're relevant. Their mortality, their death from prostate cancer, as well as recurrent prostate cancer. And this is how Prolaris works, and it's very similar to Oncotype. I think the way that I describe this, and this is the first authors right here on the podium here, Matt, pivotal paper in JCO, and I'll have you just focus on the right-hand side of the slide there. And on the x-axis is the kappa-S, or just what we would, with clinical variables, how we would predict someone might recur. And if you look at the lower risk group down here, if a man walked in and we just used clinical variables, I would say, oh yeah, you have a 10 or 20% chance of having a recurrent prostate cancer in the next 10 years. Okay, that's the kappa-S predicted 10-year recurrence, 10 to 20%. But if we use a test, and in this case it's Prolaris, in the next case it'll be Oncotype, but very similar theme. If we use a test, then we get the little dot. And instead of saying you have a 10 to 20%, I could find which dot they are, and it actually broadens the scope up to 35, 40% chance of recurrence all the way down to less than 5%. So that's what the test does. It goes from telling a patient, oh, you have I think 10 or 20%, but then you can say, oh no, you're at the 35th or you're way down here. So it broadens and improves how we can talk to our patients about, in this case, chance of recurrence, but really in the case that in cases we're going to talk about, just the risk of having bad disease. This is a sample report. Now, I'll apologize to those of you in the audience that are using these tests, because this isn't the most current one. They're evolving every few years, every few months in some cases, because the companies are improving them. So this is a little bit of old Prolaris report, but I put it here to show the relevant points that you get when you order this test. And again, I know a lot of you order these tests already, so you see these reports. But for those of you who don't, it's important to look and see what's on the test. And there's multiple different aspects about the test. First of all, it gives where they are within their distribution, within their risk. It also will tell them a 10-year mortality risk, which is almost always very, very low. It just is. 10 years mortality for prostate cancer, even higher risk prostate cancers, usually single digits. Regardless, in this case, they give an active surveillance threshold, which I'm going to talk about in a minute, as well as a metastasis risk. So again, Prolaris, the company, has blown this out to be a 3-page report now, but they have all the components in there. I just wanted to let you know about that. There was, and I authored this with the company looking at trying to find a risk threshold for active surveillance. And what we did here in this, there were several thousand patients. We looked at their Prolaris scores, and we call it CCR in this case. And when we looked at a threshold of a CCR at 0.8, then there were no prostate cancer-specific deaths above this threshold. When you look at again, you can draw a line there. The bottom line there at CCR of less than 0.8 in both the validation cohort has literally 0 deaths. And so they drew a line right there, and they said, that's our active surveillance threshold. And I think that it's been credentialized in multiple other series, and now we have that on the report. In the Prolaris decision-making, at the end of the day, we ask ourselves, are these tests changing how we practice? And so there have been multiple decision-making studies where we would ask the physician and the patient, what are you going to do after the diagnosis? Get the test, now what are you going to do? And then what they did, all right? And so this is one of them. This is from Dave Crawford. This is a 305-patient study, yet there's another one that's well over 1,000. And they looked at the change in therapeutic burden. In other words, did they actually look like they were changing what they did based on the test? And 65% of the time they changed. And you can see there that 40% of the time they decreased what they did. In other words, maybe go from treatment to active surveillance. And about 25% they increased what they did, like what Dr. Wagner was saying, maybe add hormonal therapy or something like that to radiation therapy. It affected decision-making in all AUA risk categories. This was just a snapshot of what was happening. So let's take an example. On the low-risk line, the top line there, 135 patients. And again, what happened? In some of them, like 12.6% there, intervention to intervention, nothing changed, okay? Or in 55% of them, non-intervention to non-intervention, nothing changed. But there was, in the top line case, over 30% of them did actually change what the decision that they made with regards to treatment. So it is changing how we practice. It's changing how our patients decide, because some of this is patient-driven, of course. And this is the bigger study, Neil Shore, over 1,000 patients now. And again, you can just see there, about half of the time, there was a change in what the patient actually ended up receiving. A lot of times, it was if you look there, it was a decrease. And I think it was pushing men more towards active surveillance when we look at the registry series. So I'm going to switch gears and look at Oncotype. I think Oncotype is another very valuable platform. And again, what these all are doing is trying to find what we don't see under the microscope, or what we don't see on our EPIC chart, which is PSA grade, age, race, and so forth. How fast the PSA. We're looking at the genes. Is the biopsy an accurate reflection? Clinical features, just like I just said, don't always reflect the true nature of the tumor. And of course, this affects our decision making. When you look at just the simple question of, and we did, and I can tell probably many in the room did a lot of prostatectomies on Gleason 6 disease, and we're not doing that now. But when you do that, you see that there's upgrading quite a bit, as well as not only from 3+3 to 3+4 or higher, but also from 3+4 even higher. And in these cases, what can we do to improve our prediction for adverse pathology? And I think adverse pathology is a relevant endpoint. And so in the Oncotype test, adverse pathology is their primary endpoint. And the really key question is, if you take men that you're operating on, again, you all are seeing these patients in your clinic, there's probably 20 or 30% of them that have something that we call adverse pathology. Adverse pathology is extracapsular disease, primary pattern 4. I think none of us want our patients to have that. And it's a relevant endpoint because if you think about those men that have adverse pathology in the bottom part of this slide, and you can see how they do after surgery, the biochemical failure rate's much higher than if they had favorable pathology. You can see their biochemical recurrence in orange. The metastasis rate over time at 10 years, again, much higher, like multiple-fold higher, as well as mortality. The adverse pathology group, again, that being primary pattern 4, so that's grade group 3 or higher, or T3 disease, they're the ones that we really need to watch out for. So how did Oncotype develop their test? They basically looked at various different places in the prostate, and we said to ourselves, does the distant part of the prostate really reflect the cancer part, and vice versa? And we looked at primary and highest Gleason, and this is from Eric Klein's group. And this was the pivotal paper, taking thousands of genes and finding the relevant ones, putting them together, and then after it all was said and done in the mix, looked at which genes really predicted the relevant endpoints, which I just said, adverse pathology and biochemical recurrence, and it came out with 17 genes. Now, this is not just cell cycle, like cell cycles there, that cellular proliferation, but it's also antigen signaling, cellular organization, and so forth, and putting all these together into an algorithm. Now, there were multiple validation studies, which I'm not going to run all of them, and Matt also was the primary author on many of these studies. This is the pivotal slide I want to show, and it's very similar to that Prolaris slide I showed with all the little dots on it. Because if we took a man and one of your patients that you're going to do surgery on, and you were just to ask yourself, what's the chance of them having that adverse pathology? And you took a low-risk man, let's say the yellow one there, you could probably tell him you have about a 30% chance, if I took your prostate out, that you're going to have disease that's extracapsular, something like that. And I always look at the yellow one because that is a more common, or maybe the intermediate risk, the red one there. But if you do this test, you're going to be able to tell them where along the entire continuum, where along this line, so somewhere along that yellow line. You can tell someone now, instead of, oh, it's about 30% chance, you could tell them maybe it's as high as 60 or as low as 10. So you go from telling someone this, oh, you're in this range, to telling someone you're here or you're here, which I think is a really visually good to tell a patient where they are. So again, would you want this patient to go on active surveillance? Would you run a radical prostatectomy and so forth? And again, this has been done in multiple series. I won't run through all the data, hundreds of patients, looking at where they are with regards to metastasis, where they are with regards to death. And again, GPS predicts both those endpoints. Lastly is the utility. So again, does it change what we do? Because I think that's really important, certainly for the payers, but in insurance, but really, does it really change what we do for practice? And this is a clinical utility study published in Urology Practice, and Mark Dellera at UC Davis was the first author of this study. And again, when one looks at active surveillance decision-making in very low, and intermediate risk without GPS, and it's in that, let's look at the middle one. I always look at the middle one, the low risk. If you look at the low risk, about a third of the men say that they're going to have active surveillance, but if you do the GPS, and the GPS there is in orange, then it really literally doubles the number of men going on for active surveillance. So there's no data to ask prognostic information. It's validated as a predictor for metastasis and death. Adverse pathology, as I said, is a very relevant endpoint. None of us want our patients to have adverse pathology. And then I'm just going to show a couple screenshots of the report. Again, apologies to those of you that are using the test. This is an old report. There's updates, and there always are updates. And the major one is that they're gone away from stratification within the NCCN group, and it's mostly just within the distribution of men like them with getting this test. Again, very relevant endpoints on this report, and I'm just going to skip through to show you the relevant endpoints, that being death from prostate cancer, and again, that's usually pretty low for any prostate cancer in the first 10 years, metastasis, and adverse pathology. And adverse pathology is the relevant endpoint. And again, this will show you get this test. Now it's a multiple page test. It's not just one page anymore. And these risks of these outcomes are clearly on the report. I do want to show one example that's again relevant. This is a patient. There are two patients, let's say. They both have the same PSA. They both have the same PSA density. They both have the same prostate gland volume. And they have 6 to 12 cores, high volume grade group 1. Let's say we got and again, I call this high volume grade group 1. I think it's a good target group to get a biomarker test on. And if we got this test, there could be two different results, and these might be the two different results. Again, just look at the scores, not within necessarily NCCN group. One has a low score, one has a high score. And if you look again at the relevant endpoints, death is going to be low for both. That's just how prostate cancer behaves. Metastasis will be different. And we expect a man with a higher genomic score, again, where that's Prolaris, where that's GPS, but in this case GPS, is going to have a higher chance of having metastasis. The relevant one for this test is this adverse pathology, which is quite a bit different. Okay, you can have several-fold difference in adverse pathology based on a single test in genomics. And again, would you manage these patients the same way? Ask yourself that. Show of hands would probably be no. My reflections, and these are just editorial comments, but I'm not sure we need additional tests in these low volume 1 core, 2 core. There's multiple series out there. The Pivot trial, the Scandinavian trial, the Johns Hopkins cohort on active surveillance. Universally excellent outcomes. And again, they're usually 1 or 2 cores of Gleason 6, PSA less than 10. Do we need another test? Probably not. I think our mortality and metastasis really good endpoints for active surveillance in low risk. Probably not. They're always single digits. And there's really nice work being done. This is from Scott Eggener, the Aoe Guidelines. They basically said the biomarkers might improve, but only if they're additive, and they gave example scenarios. And these example scenarios are a take-home point, in my opinion. There are certain patients that do well with these tests, and they give some examples here. I think high volume grade group 1 with a high PSA density, maybe some low volume grade group 2. Okay, those are good patients that we should consider, but they're not recommended for routine use. Now, I couldn't add the AUA guidelines that just came out Friday, basically. James Eastham presented that at the plenary session. In the AUA guidelines, it's very similar to this. The AUA guidelines said, use them selectively, don't routinely use the biomarkers, okay? So take-home points. For Prolaris and Oncotype for my section, but very similar to what Dr. Wagner was saying, they independently predict disease biology. They do. There's no doubt they do. They have multiple validated studies. The active surveillance threshold is nice to aid in decision-making. The utility studies do show they change what we do. I think that's very important. There are some caveats. And I mean, they were mostly all done in patients who had already had prostatectomy. They haven't been done that much in a long-term series of active surveillance. I question that a little bit. And then again, low-risk patients, I'm not sure metastasis or mortality really matter. So questions for this part? Yeah, sure. Yeah. Oh, yeah, good question. There have been, Matt might know, did you have a study on this a little bit, like comparing the studies? Have you had
I mean, like you, we have a few dozen patients, but nobody's done a formal head-to-head.
No one's done a form. I mean, my personal feeling is no. I mean, I think that they test different genes, but the idea, and you can see how robust the data is even between those tests, and I think that they do a good job independently. There have been a few studies that have tried to look at them head-to-head, and they're not really fair studies because some of them are not actually doing the test. They're doing like a in silico, we call it in silico, just in a gene test by themselves. I haven't seen them to be very robust in those data. Do you know of any?
Yeah, we did a paper that I popped up
Yeah,
with
that's
22
right.
patients, and our Cronbach alpha coefficient was 0.75, meaning they jive 0.75.
That's pretty good.
You know, but when they don't jive, just because one told you should do nothing and the other one tells you should do something, they both, one's obviously crystal ball, one's right and wrong, but we don't know. We don't know. I'm sorry?
Yeah, which test is the best, guys?
Yeah, that's easy. No, and there is no best test.
No.
And that's what I started with. I think you have to, talk to people, read the literature, decide what you think are endpoints, and then I do think it depends on your volume. So for us, we're at tertiary centers. I have guys coming in the door every week with one of these tests. I need to understand them all. And then once in a while, I can tweak it a little. So if a guy really wants to know, what are my chances? I want to watch it, but I'm a little worried about doing that. What are my chances of dying if I watch it? Then I might use Prolaris because there's something on the report that gives him a better idea of that than he has right now. And if I have the gentleman who wants radiation, but he wants to avoid ADT, then I think Decipher might be a better test for that particular gentleman. So it depends. So sometimes there's a specific question they have, then I can pick a test. Otherwise, I swear on my mom, I've got an app on my phone, and I can hit a button, and it rolls dice, and then it says Prolaris, Oncotype, or Decipher. And when they're really up in the air, I do that, just to let them know how I think these are all valid tests. Because I have to disclose, what I've done and, et cetera, and I take that into account.
Yeah, you want to have a comment, Matt?
Oh, sure.
Go
I mean,
ahead.
I guess two comments. One is, and this I've been a record about this for a long time. One of the comments I made at the beginning is and these tests are all expensive. For them to have value, they need to improve on what we already know. The NCCN is a terrible way of risk stratifying prostate cancer. It's completely outdated. They've now dropped the very low risk classification, which is great. It's a step in the right direction. But this whole FIR, unfavorable, intermediate, we can do so much better with tons of tests, tons of models that have been extensively well validated at this point. You can use Stevenson nomogram, the Capper score. There are plenty of things out there, and these tests all improve on true multivariable risk prediction systems. But for me to spend $4,000 to substratify the NCCN classification, I can already do that for free with the Capper score or something like it. So I don't love the subset of the reports that are kind of structured according to the NCCN, and that's a shrinking. Oncotype is the only one that still does that. And it's much less highlighted now than it was before. So in terms of the way the results are actually presented to the patient, there's a lot of science that goes into developing these tests, right? We all, those of us in academics work with the companies, there's really good statistics behind it. The reports tend to get made by the marketing departments. And the reality is there is a science behind decision-making that is not necessarily reflected. There are people whose whole academic careers are in how to present really complicated quantitative information, which is what this is, to patients with very variable numeracy. And that expertise is not typically reflected in any of them. So I've actually really migrated toward really just taking the score and interpreting that with the patient in the context of their overall disease state, and really ignoring the reports to a large extent. So that's one comment. The second is, and the science is all very similar behind them. In other words, the clinical accuracy is probably very similar across the three tests. For those of us in academics, there is a big driver to use Decipher over the others because they're running the whole genome on every clinical specimen. So even though we get the Decipher score, we have a full transcriptome in our back pocket with every clinical specimen. So again, from a research standpoint, that's been a major driver of big academic practices to choose Decipher over the others, but that's got nothing to do with clinical practice.
Yeah, my only other comment would be that Decipher was built on higher risk disease, and it was. And so editorially, I think that I would use that in higher. It was a metastasis endpoint for really bad players, okay? And so I wonder whether that can be translated to your low grade or even favorable, 3+4, because a lot of those patients were metastatic that they designed that platform on. So it's a tough one for me. If the higher the risk the man, and you're going to hear this next section about post-prostatectomy, which I think is really, where Decipher makes its most hay. So. For Confirm MDX, in the pre-diagnostic setting, I don't. Did you cover Confirm? I don't recall. Yeah, Confirm it's very interesting. So Confirm is a really nice test. For those of you, just briefly, man has a biopsy. It's negative biopsy. There's still some question about whether he has prostate cancer. The Confirm is sent on that biopsy tissue that you took, and it's on the normal tissue, and they do methylation. It has an NPV, a negative predictive value of over 90%. So in other words, you get a Confirm on that negative biopsy tissue. If there's no methylation, if it's a negative test, it's a pretty nice tissue-based ancillary test for the diagnosis of prostate cancer. But again, it's only after a negative biopsy. And I don't know, we're using it. It's actually really
Yeah,
nice.
we use it as well.
Yeah. You can use it on ASAP. Mm-hmm. And PIN, I guess. That's what they're saying now, right?
Yeah.
You had a question? Yeah.
Is there any point doing genomic markers on high grade, like group 4, group 5? You already know that will be bad, so is there any point doing that?
So it's a tough thing. I don't think there's any great indication unless, again, there is some data showing now that it can predict the need for hormonal therapy or length of hormonal therapy with radiation. There's been a couple papers that have looked at the Decipher test for that. I agree that I'm not so sure that there's great utility for us surgeons, most of us are surgeons here in the room necessarily. As an editorial comment to Matt's talk, and it's actually on the NCCN Guidelines, if you have a man with grade group 4 or 5 cancer, it's recommended actually to get germline testing now. So I think that's an ancillary test that we should start getting because it could affect things later, as well as downstream or cascade testing for their offspring or family. Any other questions? Mm-hmm. Mm-hmm. Yeah. Well, we think that there might be some of that eventually at some point in time. I mean, we're starting a platform of studies where we'll take men with Gleason 8, 9, 10 cancer. We're doing their germline. If they have a defect, we're giving them something even before surgery. It happens in other tumors. I mean, again, many of you have family members with lung cancer, colorectal cancer. I mean, we're doing trimodality therapy for most cancers. Why is it that prostate cancer, we say you either get surgery or radiation? It doesn't make sense to me, but we'll get there eventually. Oh, yeah.
Great question. Yeah.
Yeah, so, do you, Matt, you want to answer?
That's a great question. If you remember the markers, overview slide, active surveillance is up and to the right? So the same principle applies again, that you got to use the clinical information first. So Dan and I actually collaborated together on a paper looking at the Canary Consortium 2 years ago and published a model looking at the clinical variables alone. So things like PSA trends over time, whether you've had negative biopsies after diagnosis, PSA density or prostate size. Factors like this, we can already substratify out about a quarter of the men on surveillance to say with 80 to 90% accuracy, you're good for 4 or 5 years. So not to say go home and forget about it. We can't yet undiagnose some of these guys, which I think we'd like to do, but we are definitely starting to tailor the surveillance intensity based on a deeper look at the clinical information. So then the question becomes, can we do even better with Decipher or Polaris or Oncotype? The answer will be almost certainly yes, but we're not there yet. We haven't done the studies yet. I mean, there's, my heuristic on this is, okay, today we can find 25% with 80% accuracy. You add a biomarker, if it comes back 16, which it usually doesn't, 16 is a low outlier, that guy's good. He could probably practically be on watchful waiting. But I think the point will be if we get a reassuring marker on top of a good Canary model score or whatever it's going to be, we can stretch that out even further.
Yeah, I'm definitely using it. If I have a guy who has an Oncotype score of 29, so he's just into my cutoff personally is 30, that guy might biopsy in a year or two. If he comes back with a score of 8, I might go 3-5 years, if his MRI and his PSA and his rectal examination stay stable. So I definitely take it into account. But again, there's no firm, here's the algorithm. It's just sort of gestalt, right? MRIs, too.
Yeah, I
It's a whole
mean,
different MRIs and biopsy surrogate is a whole different.
yeah, I mean, I think, so my personal thinking is MRI performs much differently in active surveillance than a man who's been biopsied multiple times, sampled multiple times, rather than MRI's performance in a undiagnosed patient. And MRI's utility and performance starts to drop off in a man who's had 48 needles put him in over the last few years. It just doesn't work as well, unfortunately. So.
Although interestingly, I mean, we had a paper out from the ECSF cohort 2 years ago, and there was just an abstract yesterday along very much the same lines that so just to step back, the Music Consortium in Michigan, their quality measure now is you need to do a confirmatory test within a year, but they are accepting MR and genomics as a surrogate for the biopsy within a year, which personally I don't think we're there with the data. So MR specifically, for that first confirmatory biopsy, the negative predictive value for MR was only in the 70s, and if you have a high PSA density, it was in like the 50s. But that's for the first confirmatory test. Now, once you get into surveillance, you've had a couple biopsies under your belt. At that point, if the MR is negative, the NPV is much higher. And if you've got 2 biopsies already done, third one comes up, MR is negative, and the PSA density is low, then the negative predictive value for the MR is in the
It's very high. It's over 90%.
So, but it's a long answer because it's getting much more tailored, and it's getting much more, everybody's got their protocol. We haven't used the UCSF protocol in like a decade. These things really get very much, at the point of care tailored, which is appropriate, but it also makes it harder to study.
Yeah. And I'll refer you to their AUA guidelines. So the AUA guidelines that just came out last week says MRI cannot replace a surveillance biopsy very clearly. Okay, very, very clearly. So.
Great. All right, so we're back to our index case. So the gentleman had an Oncotype test, with GPS was 42, so that's above my cutoff of 30. So he undergoes a radical prostatectomy and has some unfavorable features. He's extracapsular disease and he has a positive margin. So quick show of hands, how many people in the audience would give this gentleman adjuvant radiation therapy based on 3 randomized prospective trials, which we usually use as the standard of care? And how many would observe based on studies like radicals and raves? And how many would order molecular testing? Great. All right, so I'm going to step in for Dave. Dave would have had no disclosures. I already gave mine. So, gentleman undergoes a radical prostatectomy, and then the question that you have when you're sitting with that gentleman that we just discussed as our index case in the office is early radiation therapy, be that early salvage or adjuvant or observation, and if the gentleman has recurred, what's your treatment intensity? And again, right now we're making these decisions based on typical clinical parameters. Already went through these slides, talking about Decipher again. The endpoint is metastasis, and the report looks very similar to the biopsy report. And it's a continuum 0 to 1.0. And after surgery, if you have someone who has a high-risk Decipher score, which is 0.60 or above, that's a gentleman that you might want to consider for early radiation therapy. Whereas if they're a lower risk score, and I usually personally include the intermediates in that group, you're moving toward observation. If you've done a radical prostatectomy and the PSA rises, again, we can get into probably a half-hour debate about what's your definition of a PSA recurrence, but now you've decided that that gentleman needs salvage therapy. Are you going to give him radiation alone? Or would you give him radiation with ADT, which is really currently the standard of care based on Rtog 9601 and Gettig 16. Number of studies, these are all in your PDFs, so any of these you want to look at to see the really hardcore evidence-based literature, I would encourage you to. So this is a study that came from DEN. I personally have this in my Epic to show patients. And what they did is they took their patients that had adverse features, and what they found was if they had a low Decipher score, it didn't matter if those gentlemen received their early salvage or adjuvant radiation therapy for a PSA less than 0.2, which is traditionally sort of the surgical threshold for cure, although I think most of us are sort of lowering that threshold. But if they had a high Decipher score, the men who got their radiation before the 0.2 cutoff did better than if you waited after the 0.2 cutoff. And it was really this study, I think, that enabled Decipher to get their approval really from the government for coverage pretty early, because the thought process, I think, was that with all these guys, and in my clinic right now, the gentleman I operate on, it's about a 45% adverse pathology feature rate. It's really high. So if you're going to radiate all those guys, it's a lot of money. But if you can sort of tease out who really needs it and doesn't, that might be a good test. And I think that's how it got approved. I don't know, and again, with the show of hands, I don't know how much people are really doing that. A lot of us are sort of observing and then going the early route. The group at Jefferson, and Dennis from Jefferson as well, they looked at it a slightly different way, sort of prospective, but not entirely. And what they did is they said, okay, you have adverse features, and now we're getting a Decipher test on you. If you have a good Decipher test, you don't get radiation. If you have a bad one, you do. But patients obviously, hear our recommendations, and then they do what they think is best. And what they found was if you have a low or intermediate Decipher score, if you follow the recommendation of observation or you got treatment, it didn't matter. Right? Those guys do okay. But if you had a high Decipher score and you listened to them and you received treatment, you did better than if you didn't listen to them. So it's another way, I think, of showing that the higher risk men probably deserve treatment a little bit earlier. And again, some other studies sort of supporting this that I'll just breeze through just to stay on time. So we looked at our cohort at our institution with 203 radical prostatectomies with adverse pathology. In most institutions, the chances of having a high Decipher score on that cohort is about 45% or 40% rather. Ours it's 63%, and that's been over the years. For whatever reason, I have a higher rate of high Decipher scores. A lot of those guys develop biochemical recurrence within the first 20 months, and we define biochemical recurrence very strictly. They had to have an undetectable PSA. And what we found was that a high Decipher score was associated with earlier salvage radiation therapy, and a higher Decipher score was associated with traditional salvage. Now, this is a little bit self-predictive, right, because I'm ordering the test, and then I'm sort of doing what it says, but it also shows that the guys are listening to this, believing me, but also Decipher wasn't designed to predict biochemical recurrence. It's for metastasis, but it's part of the pathway. You would sort of expect these outcomes. So here's a gentleman who has extracapsular disease. You see his clinical parameters, and you see him postoperatively, run a Decipher on him, and it's 0.30. So in my clinic, what I do with that gentleman is I watch him, and if his PSA 2 years later starts to creep up at 0.03, 0.06, I sit tight. He's continent, has Mets erections. I'm going to wait until his PSA hits 0.20 because the studies sort of support doing that. If I have another gentleman who has a Decipher score of 0.80, same sort of parameters, and his PSA is undetectable for 9 months, and in a year, it's 0.03, and then it's 0.05, and he's doing well clinically with his continence, I'm going to offer that gentleman salvage therapy. And right now in my clinic, 80% of patients receive their radiation therapy in a salvage setting with a PSA less than 0.20, as opposed to years past. So once you've decided that someone deserves salvage radiation therapy, Decipher can also help you, perhaps, decide on treatment intensification. So this is the Rtog 9601 trial that a lot of people are familiar with that supports adding androgen deprivation therapy to radiation in a salvage setting. What Decipher did is they took that cohort and they ran Decipher on it. And what they found was if you had a low Decipher score as opposed to a high Decipher score, your chances of developing metastasis in the gentleman that had the higher scores was 11.2% as opposed to 0.4%. And again, this was a randomized trial, ADT, no ADT. And it was really, even in the overall survival, if you had a low Decipher score, receiving ADT was actually detrimental. So the idea behind this study is maybe we can tease out those gentlemen that resulted in a positive Rtog 9601 study supporting androgen deprivation therapy to tease out who really needs it. So here's a gentleman who had a positive surgical margin, grade group 2 disease. His post-op PSA is 0.25. He's a non-nader. His Decipher score is 0.30. So he deserves radiation therapy with that PSA. His metastatic evaluation is negative, but maybe you give him radiation alone. And if you had a gentleman who had a higher Decipher score, that gentleman might receive a short course of androgen deprivation therapy. So again, multiple studies, looking at this arena. In the NCCN Guidelines currently, Decipher is recommended to inform adjuvant treatment if adverse features are found post-RP. And as a footnote, it can be considered in the post-RP salvage setting. So again, footnote, but recommended now for your adverse features. And again, just to show you the pathway, bad pathology, post-operative visit, are you going to observe or radiate? And if you've decided that the patient needs salvage radiation therapy, is it going to be radiation therapy alone or radiation therapy with androgen deprivation therapy? So Prolaris can also be used in the post-prostatectomy setting. Dan already told you the sort of outcomes and how the test is used, but you get a Prolaris score, and this is clinically validated to determine your 10-year risk of biochemical recurrence. So when you combine the cell cycle progression score, I find this a little confusing when I'm looking at the paper. So the CCP is cell cycle progression. CCR is when you combine the cell cycle progression with the CAPRA. So it's combining the sort of molecular score with clinical factors. So Prolaris does that, Oncotype does that, Decipher does not incorporate the NCCN. So that's one of the answers to the test question. So a lot of published data on this in the post-prostatectomy setting. Again, another article from Matt published in JCO. And what it showed was that the CCP combined with CAPRA, so that's the CCR, predicts biochemical recurrence, and it may improve the accuracy of risk stratification beyond CAPRA, and that's what we're talking about. All these tests, if they're going to be useful, has to do something a little bit better than we can do with the clinical parameters. Swanson in 2021 showed that Prolaris post-prostatectomy predicted both metastasis and death. So this is beyond the biochemical recurrence. And then Troke looked at 209 patients in 2021, again showing that the CCR was strongly prognostic. And I thought that, that this was an interesting study. It was showing it sort of in a different way. But if you were post-prostatectomy, your chances of metastasis-free survival with a cutoff of 2.42 seemed to be the right cutoff. And that was validated. And when you combine that study with the Swanson study, they cross over in between 2 and 3, right? So that 2.24 number seems to be a very validated number, both by the Troke study on its own, but when you look at it compared to Swanson, right? For the lower ones, one says, oh, you're gonna do a little worse than we think than the other, and then they sort of cross at that point. So that seems to be a good cutoff point for Prolaris to decide on maybe earlier salvage therapy. So to summarize, Prolaris in the post-prostatectomy setting, it further stratifies patients within each risk category. It identifies many intermediate and high-risk patients without additional high-risk pathologic features that are at high risk for both biochemical recurrence, metastasis, and death. And those are the gentlemen you might want to consider adjuvant therapy, if you believe in that, or early salvage therapy, which is what I tend to do more with PSAs that are lower in the 0.05, 0.09 range. It's prognostic. Prolaris post-RP was a dominant and co-dominant prognosticator of all the parameters that we just talked about. So questions about any of these tests in the post-prostatectomy setting, how we use them, what are we doing adjuvant or salvage?
I have a question for both you guys or anybody else. So a patient has favorable pathology, Decipher score off the chart low, like 5th percentile, and PSA keeps going up. After surgery. Are there patients who we can just say, go home, never check another PSA, you are cured?
Wait, so why did I get the Decipher? Was it on his biopsies, or why did I?
We got a lot of them just to kind of populate the
Oh.
No, and actually when the PSA, no, I'm sorry, what I'm thinking about when the PSA started rising, we got the Decipher.
Oh, then you get it.
We got,
So if his PSA is 0.05, 0.0,
0.05, I think we got the Decipher, let's say at 0.5, something like that.
At 0.5.
PSMA negative, repeatedly, and now the PSA is 5.
So 5.0?
5.0.
Oh.
Decipher very low. Has not wanted radiation. Favorable pathology. What do we do with this?
So I think I would want him to get radiation if he had no metastasis. I probably would still want that. Then the question in my head would be, do I want ADT given that low Decipher? Based on some of these studies, I guess you could suggest no. And then it would depend how far out he is from surgery, sort of plays a little bit of a role in my decision too. Years, yeah. I would probably, years, then I'm more apt to do radiation alone than I am adding the ADT. And then you throw the Decipher in there too.
Yep.
I'd probably just give him radiation. Dan, what would you do?
Yeah, I would have given radiation a long time ago.
Yeah.
Yeah, no, we had that conversation, Peter, but Peter, Dr. Carroll at our place led a multi-institutional study talking about the overdiagnosis of recurrent prostate cancer. This was with Ruth Etzioni at Front Something like 30% of men with a PSA recurrence just have a PSA recurrence, and nobody ever died of a PSA. So, I don't think we've got data, but it has always intrigued me to consider if you've got good pathology and a good genomic score, are there men that we can just say you are done and not follow them for the rest of their life with serial PSAs? I don't think we have the data yet, but it's a place that I think the
Yeah.
markers could help us down the road.
High-grade disease, right, prostatectomy done, extracapsular extension, PSA is undetectable. Would you consider radiation afterwards?
So yes, because of those the adjuvant prospective trials, and I tell patients about that, but then I tell them about the other trials, and then I tell them I would rather on that gentleman get a Decipher. So I do routinely on the high-risk gentleman. And then if your PSA twitches, I'm going to recommend salvage therapy for you. And if you stay 0 forever, you're cured. I don't care how high your Decipher is. So that's what I do. So I don't do adjuvant personally. I offer it, and occasionally a gentleman wants it and jumps at it, but not very often.
Yeah, I mean, the stepping back, the pattern of failure for somebody that's Gleason 9 and bad diseases like that is not usually just local only. And so I'd rather not just give adjuvant because most of them are giving prostate bed only, maybe a little bit of pelvic. I'd rather wait for a biochemical recurrence because it's usually going to be distant failure, in which case then we can start thinking about other things. PSMA PET, we'll find a node. The last thing I want to do is give the guy pelvic radiation and just barely miss that node that's right out of the field. Not to say that I have data to support it, but I think the field now is going more towards PET imaging for recurrences rather than just give everybody radiation and blast everything. So I think we're going to get to the point where we're going to be much more sensitive and specific and personalized.
I'm going to ask you a question. I want to ask him one, though, first, if I can be rude and hop ahead. Trouble getting them? Like, I have a lot of companies now are using a PSA cutoff of either 0.5, 1.0, and 2.0, and it takes a peer-to-peer for me to find out that that's their cutoff, which they could have just told my nurse and spared me a phone call. Are you guys able to get them? I'm having trouble with like a PSA 0.23. He needs treatment. I can't even get a PSMA. You guys or no?
Well, we're doing it locally, so, yeah, we have a generator. What we're doing, if we can't, we're just doing it on our own machine, but, and do it on a research protocol. I've had a few times where it's a problem, but I haven't had anybody pushing back at a threshold of even 0.25, so.
Yeah, we do. And you?
We're the same. We,
Yeah.
Tom Hope.
Lucky.
Love this house. We do it in-house, but the peer-to-peers are.
Torture. All right, I'm sorry, question.
Peer to near peer.
I think just a comment. Dan's answer about that extra capsule extension would be the same answer for the focal plug margin.
Yes,
It is.
yes, yes,
It is.
for sure.
No, those.
Yep.
Some of those are destroyed by cautery. Some of them are false positive. Some of them are. I mean, there's you know, undetectable ultrasensitive PSA is an unbelievably good negative predictive value for clinically significant persistence.
All right, so we'll just finish with the index case. We had another case, but it was, I think this is much better having all the interaction during the course. But this gentleman had a positive margin, like we said, extracapsular disease. I did a decipher of 0.76. His PSA was detectable for a year and a half, but then he went from 0.03 to 0.04 to 0.07. So it's real, it's climbing, it's not a lab error. So he received salvage radiation therapy, and based on some of the studies we showed, I also gave him a 6-month course of androgen deprivation therapy. So really want to thank everyone for their participation in today's course. Strongly encourage you to fill out the evaluations, chance to win a free trip to, or at least free registration, not a free trip, that's a little strong. Free registration for Chicago, and also fill out your post-test questionnaire, perhaps a $150 Visa card, and we'll be up here for a few minutes, happy to answer any more questions.